everyone, welcome to My Fences and the European Fertility Society. We are back with our topic and our guest today. Dr. Harry Karpouzis is with us. Hello, Dr. Harry. Welcome back to My Fences. How are you feeling? It's already 9 p.m. for you, isn't it right?
Yeah, it's 9 o'clock here. Nice to meet you again and everybody. And I'll be happy to do another webinar with you.
We are definitely happy to have you here. Just so everyone knows, Dr. Harry Karpouzis, he's the founder and scientific director of Pelargos, which is located in Athens, Greece. So that's why it's 9 p.m. But of course, we are here to educate you, to answer some of your questions at least. So as always, please remember to put those in the chat. We will start with the presentation on our topic, which is definitely not an easy topic. Dr. Harry has prepared a presentation on recurrent pregnancy loss. And of course, this is our topic today. He will walk you through all the details that you need to know, you need to remember, and then there will be time for your questions. So please just put those in the chat so that Dr. Harry can simply answer them for you. Remember that you need to provide us with your details like age, etc. Sometimes I know it's something that is omitted, but remember, this is also important whenever we are answering any of the questions. So please keep that in mind. You can put the questions in the chat now or during the presentation, and you can definitely do that. I see that someone cannot see or cannot hear anything, so my advice is just to refresh. I will put this in the chat in a second while Dr. Harry starts his presentation, but everything is working. I think everyone else can hear us and see us, so everything should be okay. There might be a problem with the browser. It happens, but I will write this in the chat in a second. And I think that we can go ahead with our presentation first, and then, as I've mentioned, don't forget to put the questions in the chat. Okay, Dr. Harry, ready to start your presentation?
Yes, I'm ready. Thank you.
Glad to hear this then, and let's go ahead then.
Okay, hello to everybody. We will talk today about recurrent pregnancy loss, recurrent miscarriages, challenges, causes, and solutions. First of all, let's start from the definition. Nowadays, the definition, according to the American Society for Reproductive Medicine, is that we say that we have recurrent miscarriage when we have 2 or more consecutive failed clinical pregnancies documented by ultrasound and or histology. It used to be 3 or more consecutive, but I think it's a nice thing that it has changed because investigations this way start earlier, and miscarriages are very difficult psychologically and physically for a pregnant woman, for a couple that is trying for a pregnancy. So it helps, relieving a lot of help when you start investigating about them earlier. 15 to 20% of the pregnancies conclude in miscarriages. The percentage is smaller in younger ages, bigger in ages more than 40. 1% is supposed to be the percentage of recurrent miscarriages. What weapons do we have to investigate about recurrent miscarriages? Because when someone comes with a history of recurrent miscarriage, we need to jump to the next stage and to investigate about it. There are many tests, many things that we can do. First of all, check about the sperm, DNA fragmentation, oxidation, Y microdeletions. Then checking about thrombophilia, checking about the uterus and the tubes, HSG, aquascan, HICOSI, hysteroscopy, a camera procedure inside, karyotyping, chromosome analysis of the couple, laparoscopy to investigate about endometriosis, several tests like IMAP test, endometrium test, which we will talk about later. Immunological profile tests, because recurrent miscarriages are associated with immunological background in many cases. Karyotyping of the products of conception, investigations about infections like CMV, like toxoplasma, like herpes, like ureoplasma, like mycoplasma. Let's start about the causes. First of all, chromosome abnormalities. They participate in 50% of the cases of recurrent miscarriages. It means that chromosomes are not fitting well together and the embryo is not developing and miscarrying. Genetic association. It has been proved that there are about 14 genes which nowadays can be investigated with specific tests that are associated with recurrent miscarriages. Uterine abnormalities like septum, cervical incompetence, Asherman syndrome, fibroids, polyps. Hormonal imbalances like diabetes, like polycystic ovaries, like thyroid abnormalities. Immunological like lupus, antiphospholipid syndrome, natural killer cells. Endometriosis, thrombophilia, which means blood clotting, infections like chronic endometritis, like CMV, like toxoplasma that we talked about before, and of course lifestyle like smoking, obesity, alcohol. Let's start talking one by one. Alcohol. How does it affect? It can affect the fetal development. It can cause nutrient deficiencies. And the more alcohol someone is drinking, the more it creates risk of miscarriages. It is supposed to be in some reports that it causes 7% increased risk per week if drinking. And some reports say that it is not dose related. So, I mean, the advice that we usually give is to abstain entirely or reduce if it cannot be entirely in less than 2 units per week. Smoking, another factor that is associated with recurrent miscarriages. It produces carbon monoxide, it reduces the oxygen, and these harmful chemicals that are included in smoking can cause problems with the placenta, can cause inflammation, and the more cigarettes you smoke, the more you increase the risk. And all these things, I'm saying them to say that lifestyle modifications can also help. And if you are one of these patients that smoke, drink, it always helps to decrease or stop. Obesity, a very important factor. It causes increased estrogen, it causes hormonal imbalance, it causes chronic inflammation. It is associated with polycystic ovaries, insulin resistance, and the more increased the BMI, the more increased the risk of miscarriages. PCOS, which is sometimes associated with obesity, sometimes known. It causes hormonal imbalances. It causes increased androgen, estrogen, progesterone, insulin resistance, chronic inflammation, late ovulations, not proper ovulations, and all these things are increasing the risk of miscarriages. It's considered to be 30 to 50% in comparison to 15% in the general population. Are there any things that we can do about it? Yes, metformin is a medication well known that can reduce the risk together with inositol. Endometriosis. Endometriosis is associated with many different things. It is definitely associated with infertility. Is it associated with recurrent miscarriages? Yes, it can be associated with recurrent miscarriages as well, because it causes an inflammation which interacts with the endometrium. It causes hormonal imbalances, it can cause scar tissue, and this scar tissue can affect the tubes, and then the fertilization cannot be proper, the embryo cannot be proper, quality of embryo cannot be proper, and sometimes this is a factor of miscarriage. Also, it is associated in many ways with the immune system. And the more severe the endometriosis, the more the risk of miscarriages. Can the treatment of endometriosis help? Yes, it can help, either medical or surgical treatment. Thrombophilia, blood clotting disorders. It can cause placental insufficiency. It means that the placenta is not enough to feed the embryo. In later weeks, after 12 weeks, 20 weeks of pregnancy, it can cause preeclampsia, abruption. We know that. And with thrombophilia, because there are many different thrombophilias, if we do genetic testing, There are about 17 different mutations. Not all of them are associated with miscarriages, but some of them are associated with miscarriages. The most common are factor V Leiden and MTHFR, and actually especially homozygous for these genes and not heterozygous. Every different thrombophilia has a different management if Clexane and anti-clotting injections and aspirin is needed or not. And if there is a thrombophilia, the team must include a hematologist to help with. Antiphospholipid syndrome, a very common, not very common actually, but an important reason of recurrent miscarriages. It is an autoimmune disease. It is found by blood tests, and the diagnosis is coming when we are having 3 miscarriages in the first trimester or 1 late miscarriage. And it interferes with the implantation of the embryo. It causes antibodies to attack the embryo. It can cause placenta insufficiency because of the blood clotting. And when we identify it, the solution is anti-clotting injections like Clexane, is aspirin, is steroids sometimes, or even Placanil, which is a medication that helps with thyroid abnormalities and imbalance. We know that the ideal TSH in women trying for fertility and for a pregnancy is less than 2.5, especially when the ADTPOs, antibodies are high. And when we have a high TSH, then this might mean a hidden hypothyroidism, and this affects and can cause a miscarriage. Regarding the opposite thing about hyperthyroidism, it's not clear. There is not a clear link. Thyroid hormone requirements increase with the pregnancy, and many people that were in medication before, they needed to increase the doses so that they can maintain a right balance. So endocrinological follow-up in women that have problems with the thyroid is very important to prevent the risk. Now, let's go to a very important factor that we forget about, sperm. In many cases, the recurrent implantation failures and the recurrent miscarriages are due to the sperm factors. And in a normal sperm analysis, we don't see things like DNA fragmentation and oxidation. Even in normal sperm analysis, if we do DNA fragmentation and oxidation, we see that about 20% of the men do have increased DNA fragmentation and oxidation. And this means that the wrong information is passing to the embryo. And this can cause either failure of implantation of an embryo or miscarriage. And how do we check about? We check about DNA fragmentation test, but it is very important as well to check about oxidation, meiosis, because many times we do not have oxidation. And if we do not have oxidation and we give antioxidants, which is a very common practice, we might make things worse. This is a very common example in cases that men take antidepressants, that actually when we do the oxidation, we see that it is not oxidation, it is the opposite thing, it's a reduction, and then we don't give antioxidants because we make things worse. What we can do to improve the chances and reduce the risk of miscarriage if we have increased DNA fragmentation? We can do sperm selection techniques like Zymote, like MAX, and also we need to know that the oxidation sometimes it needs to be even less than 0.5, because even if it is between 0.5 and 1, when we perform ICSI, we can still have issues. Y chromosome microdeletions, it's a genetic issue that can cause actually recurrent miscarriages. And this is something that we need to investigate about as well when we have a history like that. So the male factor is very important. Uterine abnormalities, I will go quickly here. Polyps, they need removal. Fibroids, a bit more complicated. If we have a submucosal fibroid inside the lining of the womb, yes, it needs clearly removal. If we have a fibroid that it is protruding inside more than 50%, yes, it needs clearly removal. If it is less than 50%, ideally, it needs removal. When it is inside the muscle of the womb, though, it gets a bit more complicated. When it is more than 4 or 5 centimeters, it is better to remove it, but we need to take into consideration other factors as well, like age, like distance from the cavity. Does it distort the cavity or not? When it is very close to the cavity, it gets even more difficult because when you try to remove a fibroid there with a laparoscopy, you might cause injury to the endometrium, and this might cause more important problems. So with fibroids that are less than 5 centimeters, they are intramural and they are very close in proximity to the cavity and slightly distorted, we need to be careful. Sometimes we remove them, especially when we have previous unexplained failures or miscarriages, but we might leave them there as well, depending on the case. Septums need to be removed and they improve the chances a lot. And all these things are happening with a hysteroscopy. Hydrosalpinx, it can cause failure of implantation. It can cause sometimes miscarriages as well. This is fluid inside the tubes, and it can happen because of chlamydia infection, PID, endometriosis, previous surgery, because of many reasons. This fluid can be toxic to the environment and also can go through the uterus and expel, actually push out the embryo. So what do we need to do about it? It needs to be removed. How do we do that? Laparoscopy to remove a tube before an embryo transfer, or sometimes when this is something that we suspect that it will be very difficult or put the patient in risk, even hysteroscopic insertion of a device to close the tubes, proximal occlusion, many things, but to prevent the fluid from going inside the cavity. Endometritis, chronic infection of the womb. This is something that it is different from endometriosis. How do we find out about endometritis? With hysteroscopy, if we know what we see, we can see things that actually we say that it might be a chronic infection here, like micropolyps, like red spots inside the hysteroscopy. And in this case, we need antibiotics. There are specific tests as well, like ALICE test, like endometrium test. They are doing the same thing, PCR, molecular tests that check about what is the cause. And then when we are doing these tests, we need to treat specifically for this. The inflammation caused by a chronic infection disrupts the implantation. Some of the studies do not show a link. Some of the studies show a link. There is a fashion nowadays about the intrauterine washing. There is no data behind it. Antibiotics from the mouth help, but if there is clear evidence of endometritis, definitely the antibiotics can help prevent miscarriages. Infections. What infections? Herpes. There is a small association. When we see it and when we know that it is the first time that it is happening, it is better to treat. CMV, toxoplasma, ureoplasma, mycoplasma. In some of the studies, they are associated. It is very important when we have a miscarriage to check about these things as well, so that we know if we have a reason of a miscarriage or not. Because when we find out that there is CMV in a miscarriage, then we have an obvious reason and we don't start thinking about other things. So it is important to check these things when we have a miscarriage, if possible, and it is always good to know that we don't have these infections before we transfer an embryo, in cases especially of recurrent miscarriages. Immunology. Immunology is an issue that is very conflicting. We are dealing with it for a long time, actually, and we are trying to apply it because we really believe in immunological issues of recurrent miscarriages. It's very complicated. I will not go thoroughly through the slides, but generally there are some natural killer cells inside the lining of the womb, and actually they have a reason of being there. They help because this inflamed environment helps the embryo to attach, and it helps with the vessel growth. It helps preventing from infections. But sometimes what is happening is that the uterine natural killer cells become killer cells, okay? And what is the reason for that? The reason is that for any reason, for hormonal imbalances, because of any reason at all, we have an imbalance of many modulators that exist inside the lining of the womb. And this is causing either underactivity or overactivity of the environment. And this helps attacking to the embryo or not supporting the embryo. There are many different things. What I want, I will not go thoroughly through all these. Of course, we can talk about it for whoever has a history of recurrent miscarriages, and there are specific tests like IMAP test that we really believe it is based in research from a very good immunologist who is called Lede from France. And what I want to say here is that many times we give steroids, we give intralipids, but we don't have a reason of giving them. The important thing when we have recurrent implantation failures or recurrent miscarriages is to investigate exactly and to personalize the immunological protocol. So for specific reasons, steroids might do harm. For specific reasons, steroids might help. We might need additional intralipid for other reasons. We might need other medication like Placanil for some reasons. And there is cases that the immunology is reversed. There are cases that the immunology is not overactive but underactive, and we need to know about it, because in cases like that, we don't give steroids. We do the opposite. We might need to increase the progesterone, or we might need to give medication like, for example, HCG, like Ovitrel injections before the implantation, before the embryo transfer and after the embryo transfer, that helps actually changing the modulators inside the lining of the womb and helping implantation and not having miscarriages. Now, the most important reason, chromosomes. Chromosomes are there in 50% of the cases, either alone or coexisting with other factors. The most common reason of recurrent miscarriages are chromosomes. So when someone is doing IVF for recurrent miscarriages, it is pretty clear that this person needs to do PGTA. PGTA is the chromosome check. And why do we need to do PGTA? Because if we don't do PGTA and we put an embryo and we investigate all the other things, we will not be able to find out in the end if it fails, if the problem was the embryo or something else. We first create a chromosomically normal embryo. And if we manage to create a chromosomically normal embryo, then we start checking about all the other things so that we can put this embryo under the best circumstances. And the results of the PGTA can be euploid embryos, aneuploid embryos, and mosaics. When we have euploid embryos, chances are as high as 74% after we investigate everything else. When we have aneuploid embryos, there is a problem with the embryo, and we know that. When we have mosaics, it gets a bit more complicated. And why it gets more complicated? Because some of the mosaic embryos are non-transferable and some of the mosaic embryos are transferable. But even if we have a mosaic embryo, we can have genetic counseling and we can have counseling to say if this embryo is worth transferring it or not. Mosaic embryos, though, if they are transferred, they have a very high risk of miscarriages. So we usually do not transfer them in cases of recurrent miscarriages. But you need to know that the result of the PGTA nowadays, if it is well documented, and when it is well explained, like in these slides over here, it does not cause any problems. It says if an embryo is healthy or not, so that we can target in other factors as well before we transfer an embryo. PGT-SR. When are we doing PGT-SR? PGT-SR is done in cases of translocations. Many women that have recurrent implantation failures, or men that have recurrent implantation failures or recurrent miscarriages, we need to do a karyotyping on them. And when we do karyotyping, we see that they have translocations. What does translocations mean? It's either reciprocal in 60% or Robertsonian in 40%. What does this mean? It means in the reciprocal translocations, it means that parts of the chromosome swap places. And the Robertsonian, it means that two chromosomes are stuck together. And when this is happening, it means that it can cause embryos with chromosome abnormalities. So people that have translocations are completely healthy people. They don't know anything about it till the time that they are having recurrent miscarriages or till the time that they are having infertility. So in people like that, we do karyotyping, and in many cases we find translocations. And when we have translocations, then we need to do PGT-SR, which is a variation of PGT-A, and we can find out embryos that do not have a chromosome abnormality before we put them back. Finally, is the protocol in the frozen transfer important? It is. There is some data that says that when we transfer in natural cycles, it reduces the risk of miscarriages. We have many different protocols. We have protocols with down regulation, with hormone replacement. We have protocols with endometriosis patients. We have protocols with natural cycle or modified natural cycle to transfer a frozen embryo. There are many things that we need to take into consideration. When someone is traveling abroad, to have a natural cycle is very difficult to coordinate it. It has a risk of cancellation. It has many issues. So we prefer to go with hormonal replacement treatments. But in some cases, when we have failures in these treatments, natural cycles or modified natural cycles might have an improvement, especially when we have checked everything else. And downregulation with medication like gonapeptyl, like Arvecap, they have an option of using them only in patients with endometriosis because it suppresses endometriosis. And or when we suspect endometriosis, okay? In people that we know that they do not have endometriosis, it is better to avoid them because they can change sometimes the environment and the immunology inside the endometrium. So the protocol that someone will choose to do an embryo transfer after we have investigated about everything is important as well. Conclusions. Importance of medical history and detailed history. It is very important to ask all the questions when you have recurrent miscarriages. And it is very important for the patient as well to give us all the data. The more data we have, the more we go thoroughly inside the whole case and we try to suspect or to find out what is happening. It can be due, the recurrent miscarriages, to the embryo, to the uterus, to the sperm, to the body. Okay, these are the 4 options, and we need to investigate all of them, starting though from the most common one, which is the embryo. PGT-A. If we don't rule out the more common reason of miscarriages, there is no reason of spending money and time in all the other tests. Choose the right protocol for a transfer. And finally, think positive. Don't be stressed. And in the end, in most of the cases, you will make it happen.
Brilliant as always. Thank you so much for your presentation and walking us through all the steps that
Hello?
we think about. Can you hear me now?
Yes, I can.
Okay, good. Just was worried for a second, but yeah, everything is fine and we can hear you. I think that you can hear us all as well. So yeah, thank you so much for that. And as you can see, there are plenty of questions already right here. And as I've mentioned, I will now go to those, and just to let you know, we have around 30 minutes for the questions. So if you have something that you would like to share with us, you would like to comment or ask, do it now, okay? And now I'll display the first question, as this is quite a longer question. So let me just go here. So I'm 51, doing IVF solo. I have 3 vials of DD frozen embryos. This is my 5th attempt, and none of the embryos have stuck, and hence I've had failed attempts. My lining is always around 8-10, and I've been told it's a numbers game. I had 3 hysteroscopies, 4 aquascans, PCR culture, microbiome test, all are fine. I've asked for an IMAP test, but not sure if this is the right way to go about, and I don't think doing the same thing is working. I do have underactive thyroid, Hashimoto. Thyroid is at up to optimal level now. In part IVF, it was around 4.5. What do you suggest? I do not smoke and barely drink. Anything you can suggest here?
Yeah, just to understand, it's donor embryo transfers, yes?
Just confirm this for us, okay? So we can make sure.
I think it says DD frozen, so most probably
Yeah.
we are talking about donor embryo transfers. Okay.
Yeah, correct. Correct.
Yeah. Okay, but I mean, it's a very, very long, question, but we don't have the whole picture and everything. I mean, as far as it regards the question, I can see here that she has done most of the things that she needs to do. Immunology, most probably, it's not very well properly checked, because when you do just a biopsy in a natural killer cell, it's not always the same like preparing the lining of the womb and taking the biopsy at the right time, like what you are doing in an IMAP test, because that comes back, for example, with a specific protocol, and says use steroids, do not use steroids, use other medication like Placanil and things like that. So if everything else is absolutely fine, if the lining of the womb is okay, hysteroscopies are okay, there is no infection at the time of the hysteroscopies, I think that the immunological status needs to be investigated a bit better. Since we are talking about donor sperm and donor egg, obviously, sometimes you might be unlucky with the donor sperm or the donor egg. So I suppose that you have tried more than one donors in all these attempts, or I don't know if they are from the same donor, because sometimes you might have an issue with the donor or the donor egg or the donor sperm as well, and the embryos, even with donation, might not be always chromosomically normal. But I suppose that you have changed donors as well. We need to go through the notes. We need in detail to discuss about the things exactly that they have seen in the tests, and to discuss about it. Sometimes when we have investigated everything, we have tried different donors, different sperm, different investigations, we have and still is failing, then we are talking about other options like surrogacy as well. But of course, we need to see it more thoroughly.
That makes sense, obviously. So thank you so much. If there's anything, yeah, yeah, there's a follow-up. Are we in position to email you? I would be happy to forward your question. And if you would like to get in touch with Dr. Harry, I'm sure he will be happy to help you out. He just needs definitely more details from you as well, right? So we can do that for sure. Thank you so much. And let's have a look. Next question is here. We'll show it here as well. Could oversupply of folic acid or vitamins B, vitamin D, be the reason for miscarriage, or too much aspirin? I took 100 a day, aspirin, right? And developed strong breath problems with it, breathing problems with it. Miscarriage happened at 11th week.
It's quite unlikely to, vitamin B or vitamin D to cause miscarriages. It's not usually a common reason for that, and it's not clearly associated when we have increased levels. Actually, vitamin D, when it is low, it is associated with subfertility, but it shouldn't be the reason of a miscarriage. Now, regarding aspirin, what was the reason that you were taking aspirin? The dose is not high. Usually, it doesn't cause any issues. Sometimes aspirin works like a blood thinner. So when we have a bit of bleeding for any reason and we keep taking aspirin, it might provoke that, but I'm not sure if that was the case with you or not. If we are talking only about one miscarriage at 11 weeks, it might have many reasons of why it has happened. First of all, it could be just chromosome abnormality. I don't know if you have sent the products for chromosome check or not. It could be other reasons related to that. So it's not an obvious reason for me, the ones that you've mentioned.
Okay, thank you so much again. And let's have a look. Next question. Could you please repeat which genetic mutation in coagulation factors could lead to miscarriage?
You mean thrombophilia, about thrombophilias? I mean, there
I
are
believe so.
many.
Yeah.
There are many of them. There are about 17 different mutations. The most common ones that are related to miscarriages is MTHFR and factor V Leiden, which, of course, someone can be either heterozygous or homozygous. If someone is heterozygous, then in a full thrombophilia check with many mutations, if there are other mutations as well, it can increase the risk. But if it is a sole mutation and heterozygous, usually it is not a reason of miscarriage. But when we have homozygous, which means two genes of that, of factor V Leiden or MTHFR, this is clearly associated with blood clotting issues, which can cause miscarriages as well. So the solution in cases like that is anti-clotting injections or aspirin or combination of them, and a hematological review, actually, because in our unit we do have a hematologist as well to talk about all these thrombophilias.
Okay, I believe that answers your question. And then let's have a look at the next one. So if there has been repeated implantation failure and I have done immunology tests that came back normal, would doing an immunology protocol, clexane, prednisolone, be determinal? I have done immunology protocol and still I have had failed implantation.
Okay. I didn't understand exactly if there was finally immunological issue or not. If there has been, let me read it a bit.
It's right here.
And I have done immunology blood test that came back as normal. Would doing an immunology protocol be detrimental? No. Okay. Listen, I understood the question now. First of all, there is a very conflicting issue behind if immunological testing in the blood really corresponds with what is happening in the uterus. Some people say that yes, some people even say that it is better. We believe that it is more important to know what is happening in the uterus. So if your immunology in the blood is normal, it doesn't mean that the immunology in the uterus is normal as well, which is identified by a test, a biopsy in the uterus. Now, if the immunological testing was okay and you were taking anti-clotting injections, you have other reasons of taking anti-clotting injections for thromboprophylaxis, for many different issues, especially if you are more than 40. So it is not that the Clexane will cause problems and will be detrimental to your IVF. No. Regarding steroids, we always prefer to give, at least us, the steroids in women that do have an issue. But not all of the people are doing immunology testing, etc. So when you have recurrent failures, you can try it in some cases, rather than putting a patient into paying a lot of money for the immunological testing. In case there is something, you can use it. But the truth is that the best thing would be to know what exactly is happening inside the lining of the womb and then to use the steroids if these are needed.
Okay, brilliant. Thank you so much. And now we will go back to the previous patient. She asked about genetic mutation, Lou, and she has another question and follow up actually. So let me just show you this. So I have Rerbinogen beta 455 homozygote and 3 further heterozygote mutations, as you can see here. Anything
It is
else you
not
can
a
add?
severe, it is not, listen, I'm not a hematologist, okay? We have a hematologist in the team. So this is very, very specialized. But to be honest with you, it's not a gross thrombophilia. It is not a thrombophilia that since you are heterozygote in PAI, one and not homozygous for that, it's not a gross thrombophilia. Now, covering with Clexane can be a case given of your doctor. So, for example, your doctor might decide to cover you one way or the other with anti-clotting injections, especially after the embryo transfer, but you might have other reasons for that as well, age-related, weight-related, or other reasons to be covered with injections, because we are not only giving the anti-clotting injections for miscarriages, we give them to prevent clots as well. But I wouldn't worry grossly with that. The decision on if you will be put into anti-clotting injections or not after the embryo transfer or during the pregnancy will be your doctor's. And to be more fair, it would be good to get a hematological opinion as well from someone who is specializing in that.
Definitely. Thank you so much. I believe that was helpful again. If there's anything else, you know what to do. Okay. Okay. Next question. So, how CMV or herpes do lead to miscarriages, or are you talking about fresh infection only, so that old antibodies are not risky, dangerous?
Yeah, it is very unclear, and I've put it over there because there are some studies that show some link. Definitely a recent infection of CMV and toxoplasmosis can cause a miscarriage. An old infection will not cause a miscarriage. Regarding herpes, it is a bit more complicated. In patients that are having recurrent miscarriages, recurrent implantation failures, or recurrent miscarriages, there are some studies that say that possible, even if it is not a new infection and it is a past infection, a coverage with antivirus for herpes medication might help. So in some of the patients that are having old infections that are coming back and back and back again, we prefer to give some medication for herpes as well in recurrent miscarriages cases, and not in all the cases. Yeah.
Okay, thank you. And do you have experience whether a long first cycle part, 21 days instead of 14 days, for example, could affect the egg quality and hence lead to miscarriage?
I mean, if I understand correctly, if the first phase is longer, then this means that the cycle is too long. So this usually is happening when we have polycystic ovaries, and of course, polycystic ovaries can affect because they can cause late ovulations, and the late ovulation might not cause a good quality egg. Usually there is a problem sometimes when the second half of the cycle is short and not when the first is long. When the second part of the cycle is short, this might mean that you are having a luteal deficiency. And in cases like that, progesterone support might help.
Okay, and now we'll go to the next question here. We just received this. So when would you start the medication for old herpes infection, ongoing suppressing medication, or only when transfer has happened?
Before the transfer.
Okay, that was just a follow-up to the previous one, but thank you. And now let me go to the next. Sorry, there are more questions coming up. So I have had a few miscarriages around week 6, 7, and one was less than a week. It seems so easy to say it is chromosome abnormality. Is there a way to test it?
Well, yes. I mean, if you have a DNC and you send the products of conception for a chromosome analysis for a karyotyping, you will find out if the embryo was chromosomically normal or not. And actually, when someone is having a third miscarriage, at the time of the third miscarriage, it would be good to check the products of conception, to send them and see if this was a chromosomically normal embryo or not. If it was a chromosomically normal embryo, it doesn't mean that the two previous were as well, but it will give you a suspicion of what is happening. If it was not a chromosomically normal embryo, then you know that the problem was the embryo. And this is an information that you get, and it can help you managing the next IVF. And when you are having 3 miscarriages and the most common reason is chromosomes. I've said in my presentation that the best thing would be to go ahead with IVF, and after you have your embryos, your day 5 embryos, you can biopsy the embryos and you can send them for a chromosome analysis, which is called PGTA. And then you will find out if you can create your DNA and your husband's DNA can create chromosomically normal embryos or not. Because if the embryos come back as abnormal, all of them, then you know it, you can see it, and you don't need to check about other things. I mean, if you have a chromosomically normal embryo, though, then we are passing to all the other things that you can investigate about so that we can make sure that we take this normal embryo and we put it inside your womb.
All right. Again, thank you so much indeed for that. I will publish the next question here. Can HHV6 contribute to miscarriage? It showed on fertilizis microbiome tests. After treatment still present, suggested to be chromosomal. Can anything be done?
Contribute to miscarriage, it showed on fertilizis microbiome test. After treatment, suggested to be chromosomal. It's a bit complicated when what you say. I mean, HHV6 cannot be like chromosomal. Usually, when we have like an infection or anything coming back in the microbiome or other tests that are done inside the lining of the womb, the treatment is enough. And sometimes you might need some probiotics as well to help generally fixing the pH and taking that out. But I'm a bit confused about what you mean chromosomal.
All right. So if you would like for Dr. Harry to take a look and just let us know what you mean by that, so that we can definitely go back to this. Okay. Thank you so much. In the meantime, let's have a look at the next question. So can there be, let me show you, endometriosis with light periods, strong ovulation pain, some intercourse pain, some light period pain? Anything you can advise here?
Light or heavy periods is not actually, a basic symptom of endometriosis. Endometriosis usually is causing painful periods. Sometimes it is causing as well painful intercourse. And these are the main symptoms of endometriosis. But we do have many women that have endometriosis, and the endometriosis is asymptomatic. It is said that if we put a camera in every woman's tummy, about 15 to 20% of the women, we will see that there is endometriosis inside. So yes, it can be asymptomatic as well. This doesn't mean that you need definitely to do a laparoscopy about it, but it is something that it gives you that you can have endometriosis even without symptoms. Of course, if there is any suspicion from the history, etc., you treat it accordingly. There are some tests as well, because the golden standard for endometriosis was laparoscopy, which laparoscopy is a surgery though, and it's not easy for everybody to do a diagnostic laparoscopy to find out about endometriosis. Nowadays, there are some molecular testing as well, which you can take a biopsy from the inside of the lining of the womb, and it gives you quite accurately if there is endometriosis or not.
Okay, thank you so much again. And now we will have a look at the longer question. So I will show you this again. So I have uterine myoma that is around 4 centimeters. I've been having increasingly lighter periods, which I have been told could be caused by my uterus getting pushed by the myopia and being less flexible because of this reason. Do you think this could be impacting my chances of getting pregnant? Would it be recommended to remove it and to have any additional treatment after? And if so, which one?
Well, we need to know where exactly is this myoma, this fibroid. If it is the only one, or if there are others as well inside. And as I have said in the presentation, if it is any suspicion that it is protruding inside the lining of the womb, then we need to check that with a hysteroscopy. And if this is the case, then yes, it needs to be removed. Now, if this fibroid is outside the cavity completely and it is 4 centimeters, I wouldn't really go ahead and remove it. If it is in very close proximity to the endometrium, it is very borderline case. Usually in cases like that, because it is small in size and if it is very close to the lining of the womb, in the first IVF transfer, we prefer to leave it without really touching it. But if we have recurrent miscarriages or recurrent implantation failures, then there is an option of trying to remove it. Surgeries with that small fibroids that are deep inside the muscle of the womb and close to the cavity are very difficult and challenging sometimes, because if you breach the cavity, if you open the cavity, you might cause worse problems rather than help.
Okay, again, thank you so much. If you have had one successful pregnancy and then 3 failed implantations, what can you do to improve your chances to help implantation?
Well, you need to investigate, yeah, because even if you had one successful pregnancy, if you have 3 in a row miscarriages, this is considered to be recurrent miscarriages. And many times things change after a pregnancy. So a pregnancy, a cesarean section, an infection at the time of the pregnancy, other things might be affected after your pregnancy. So you need to investigate. You need to check about chronic infection, to do a hysteroscopy, to make sure that there is no other reason of causing miscarriages. So I would suggest with 3 in a row miscarriages, even after a normal pregnancy, you need to go through the process of investigating and finding out what is the problem. And of course, it is related as well to your age as well, because I don't know when was the first delivery, and if you are now more than 40 years old, it does explain sometimes miscarriages in a bigger percentage. Okay, the percentage of miscarriages in women more than 40 is bigger rather than in comparison to a woman that is younger in age. Yeah.
Okay, thank you. And how to increase the success of implantation for a fresh transfer? Any difference between 3-day versus 5-day transfer?
Can you put it in the screen, Caroline?
Sure, yeah,
Sorry.
it's right here. How to increase the success of implantation for a fresh transfer? Is there a difference between day 3 and day 5?
Okay, first of all, we are not talking about pregnancy loss now. We are talking about failure of implantation, most probably, which is another issue. But first of all, it's very difficult and very broad to answer this question. First of all, you need to make a right decision on if a fresh transfer is good to be done or not, because nowadays we do have more chances or equal chances or more with frozen transfers rather than with fresh. So many times the estrogen levels, the progesterone at the time of the trigger are increased, and this might affect the implantation window. So first of all, we need to make sure that the fresh transfer would be okay to be done by checking progesterone before the trigger, for example. And then if the endometrium is okay and everything is okay, you just add whatever your doctor will say, for example, progesterones and any other medication that your doctor will say, so that you can do the embryo transfer. Now, if we are talking about recurrent miscarriages or anything like that, to be honest with you, as I've said before, my personal opinion is that when someone is having recurrent miscarriages, it is better to know the chromosomes of the embryo before you put it back, because otherwise you cannot give an answer. You don't know what is the problem. You don't know if the problem was in the embryo and the chromosomes or if it was somewhere else.
Okay, again, thank you so much. And let's have a look at the next question. So do you recommend to use progesterone suppositories after ovulation 3 days to prevent miscarriage?
In natural cycles, you mean?
Not sure. Let us know. Let me see. Yes.
For 3 in natural cycles, not for 3 days only, and it depends on if you are having like a small cycle or not. When the cycle is small, as I told you before, it might mean that you have a small luteal phase, second half of the cycle. So in cases like that, sometimes a progesterone support might help, but not in all the cases. I mean, if you do have a regular cycle, if you have a normal cycle, if you have proper ovulations, it's not, there is no need of adding progesterone, to be honest with you.
Okay, thank you. Next question, again, I will show you this. So I was told that if there was a chromosome abnormalities in the embryo that will lead to an abortion, but in more advanced stage of the pregnancy. On the other hand, if abortion happens in the very first weeks, this is more likely to be caused by another problem in the implantation state of the uterus or similar. Do you agree with this?
No, I don't.
Okay.
I mean, the chromosome abnormalities are very common even in the first trimester, and they are the most common reason. I mean, many embryos are having chromosome abnormalities and they are not getting implanted, and many embryos that are getting implanted are having chromosome abnormalities, and nature prevents them from growing more, and this is a miscarriage. And then some of them, they do not miscarry, and then you find out about chromosome abnormalities at the time of the nuchal scan. So chromosome abnormalities is the most common reason even in the first trimester.
Okay, brilliant. Thank you so much. And there are two questions left, I think, but of course, if you have any other questions, go ahead. This will be the final call for those questions. This is from the same patient, so let me just show you those. So my partner had a sperm DNA fragmentation test, has came back as 21 for fragmentation. I have been told this is a high and should be below 15. Can you please tell me what we can do about high fragmentation and what treatment is recommended? Last time I done IVF, I bled 5 days before testing day. Do you think I need more progesterone, or is there anything else that could cause this before testing date?
There are two separate questions, yes?
Yes, of course, from the
Yeah.
same patient though.
Oh, okay, all right. So DNA fragmentation, yes, 21, it's a bit high, okay. It is better to bring it down. As I told in the presentation, we usually prefer to check about oxidation as well, but if it is not done, it is okay. We know that we have DNA fragmentation, so if your husband doesn't take any antidepressants or any other medication like that, he needs to take antioxidants, okay, like multivitamins, like Proxid, like, you know, there are many other brands. Each one of them has different substances of antioxidants inside, and this might help with the DNA fragmentation. And if you are doing IVF, because DNA fragmentation is actually a selection route, I mean, if you are thinking about doing IUI, DNA fragmentation is a no. It says to you jump straight to IVF. Okay, so at the time of the IVF, there are ICSI, which is the common method, helps with DNA fragmentation, and there are nowadays sperm selection techniques like Zymot, for example, that help selecting the sperm without DNA fragmentation and puts more healthy sperm inside the embryo. So there are options that you can do about it. Now, about the other question, could be. I mean, in a second IVF, I mean, it would be good to check about progesterone levels before the embryo transfer. Usually, though, I mean, there are common protocols that usually the progesterone levels are quite specific with these protocols. But I mean, sometimes it is that, but it is not the only reason of why having a bit of bleeding before. Sometimes you have a bit of bleeding before the pregnancy test, and it is like implantation bleeding as well, you know. And then you do the pregnancy test, and it comes back as positive. But progesterone support is important, and it needs, my personal opinion, to be measured as well, because there are many people that do not check about it, but there are specific cutoff limits.
Okay. Short question. Can you overdose on progesterone?
before, after, or what?
Just a general one, but
before, well, no, I mean, progesterone levels can go very high in the body without really causing a problem to your health, if that's what you mean. But if you get too high progesterone levels, might be an issue. But again, in newest reports, even if the progesterone levels are quite high, they don't, according to some new reports, they don't even affect the implantation. Of course, the ideal thing is to have specific cutoff limits, but in cases like endometriosis, for example, sometimes we prefer to give more levels of progesterone because women with endometriosis sometimes have resistance in progesterone. I wouldn't be afraid of having, an overdose of progesterone, but of course there are specific protocols of progesterone that your doctor and any doctor can give you and can follow them.
Sounds good. Thank you so much indeed for that. Okay, next question is, some said that women get pregnant much easier in the following 3 months after a loss. Is it true? What is the logic here? Anything you can say on that?
Again, we mean in natural conception?
Not mentioned here, but yeah.
Yes. Some said that women
Following
get
3
pregnant
months
much
after a loss, right?
after the loss. Well, it's not 100% accurate that there is no strong evidence to support it, to be honest with you. Yeah.
Okay. And how do you test for sperm oxidation? Oxidative
There are,
stress, I think, right? What
yeah,
is the name of the test?
there are some tests in the market like Myoxis, for example. Myoxis, the name.
Okay. I think that helps. And let's have a look properly. Our final question here. So can women still get pregnant if she has... Okay, I need to show you this. I'm not sure. I think it's PCOS, is it? If she has IVF with fresh donor eggs? I'm not sure. Sorry.
I mean, usually PCOS, it's not
No,
a
it's
reason.
PCOD.
What's PCOD?
I'm not sure here as well, so please let us know.
I suspect that she means PCOS.
I thought so.
I mean, first of all, PCOS is not a reason for donation, but if for other reasons you have, you have concluded, yes.
Okay, yeah.
So you have
Okay.
concluded into needing donor eggs. PCOS will not actually cause big issues, because PCOS, it's a problem when the disease of PCOS is active, when your hormones are active, when you are not having ovulation and things like that. I mean, if you are getting close to menopause, you are getting older or anything like that, and you need donor eggs for other reasons, at that point, your main reason and the main problem is not PCOS. The main reason is that you are having, for example, poor ovarian reserve or other things. So PCOS will be getting better as you are getting older, and it's not a big problem. By any means, if it is associated with insulin resistance or anything else, sometimes metformin, glucophage, can help preventing a miscarriage, for example. And sometimes we do suggest it even in cases like that. But yeah.
Okay, brilliant. Thank you so much. I believe that was our final question. However, there was a question that is a little bit off topic, and actually it was about asking you whether you are hiring. I would be happy to forward this question, Sophia. This is a question from Sophia. She's a student and she's interested in looking for some options. So I can always forward this to you. Definitely. Yeah, it's definitely possible. So thank you, Sophia. for that, and of course I will be happy to send it over to Dr. Harry after we finish, so he can you can also apply, I guess, as well. Thank you so much, everyone. As I mentioned, this seems like we have covered all of your questions. Remember that if there are more questions, Dr. Harry definitely needs more information from you. This is, of course, an opportunity for you to ask and find out, but obviously he needs all the medical records to give you a lot more information. And of course, as you can see, there are plenty of thank yous coming up your way. As always, not surprised at all. A very informative session. I couldn't agree more. So thank you a lot, Dr. Harry, for joining us, for your time. And of course, thank you everyone for your time as well. I do believe it was helpful. Any final comments before we finish, Dr. Harry?
Nothing. Thank you for attending. I hope I've helped, and thank you, Caroline, for giving me the chance again to talk about so many interesting subjects.
Lots and lots of questions, right? This was intense Q&A, which we like for sure. So thank you. Thank you so much for today. And I also want to mention that, of course, Dr. Harry will be back with some more topics, so stay tuned. There are some more events coming up with him as well. And I also want to mention that next Thursday, actually, sorry, this Thursday, we will talk about hysteroscopy. So if this is something that you are interested in and would like to find out more, join us. We will be there with Dr. Elias Tsakos from Emro Clinic, and he will be happy to answer your questions as well. This is on Thursday, 7 p.m. London time. But that will be it for today. Dr. Harry, lovely to have you. Speak to you soon, and everyone have a lovely evening. And I do hope to see you on Thursday as well, and bring all the questions that you have for sure. Thank you so much. Take care.
Bye bye.